right, so I'm tasked with providing the counter-argument that surgery is standard of care, and the key points that I'm going to make is that non-operative management is not quite ready for prime time, and this is based on insufficient clinical evidence, lack of standardization, validation of the response, as well as the follow-up schedule, potential hazards of widespread dissemination of non-operative management, and concluding the fact that non-operative management is currently not supported by national guidelines. So this is a summary table that reviews some of the clinical data that's been presented. Dr. Garcia Aguilar highlighted some of these studies. I want to make the case that the prospective series are relatively few and far between, and the number of patients that have been treated on these prospective studies are relatively small. We see heterogeneity in the stage of the patients that were subjected to this approach. Some of the series had mostly early stage patients, whereas some had more node-positive patients. The neoadjuvant chemotherapy and radiation regimens that were used are quite varied, with varying radiation dose, varying chemotherapy schedules, use of neoadjuvant chemotherapy. Many of the series don't report the rates of complete clinical response in patients undergoing neoadjuvant chemoradiation, and in those that do report them, in many of the series they're quite low, including the Maastricht series, in which only 11% of patients had a complete clinical response. The follow-up for these patients is relatively short, with the exception of the Sao Paulo group. None of these series have follow-up beyond 5 years. As we can see, the local recurrence rates are clearly higher than what we see with standard trimodality therapy, with most series reporting local recurrence rates in the 20 to 30% range. And although survival appears to be quite good, with 90+% overall survival, again, it's important to note that most of these series only have 2 to 3 year follow-up. We know patients with newly diagnosed metastatic rectal cancer have a median survival of over 2 years. So if you take a patient who has a local recurrence at 1 year after watch and wait strategy, and you know they're going to live for at least 2 years even if they had metastatic disease, 3-year follow-up really is insufficient for determining whether these patients are actually going to be compromised with regards to their disease outcomes. So again, the clinical data, relatively small numbers, most series, less than 100 patients, heterogeneous cohorts, heterogeneous treatment, heterogeneous assessment. Only 10 to 30% of patients, possibly up to 40% if you intensify neoadjuvant therapy, are going to be eligible for the strategy. Limited follow-up, and clearly we know the local recurrence rates are higher than what we see with modern trimodality therapy. If you look at contemporary series, NSABP, German series, our pelvic control rates are excellent. They're greater than 90%. So we're basically assuming that it's going to be okay to take a step backwards with regards to local control. And the question is that compromise justified? A key point that Dr. Garcia talked about is, can we adequately determine who's had a complete clinical response? And most of the data suggests that single modality assessments using either endoscopy or radiologic imaging studies have a suboptimal positive and negative predictive value. More recently, some of the pioneers in non-operative management from Memorial and from Maastricht have put together multimodality assessment criteria using DRE, endoscopy, standard MRI sequences, and advanced MRI sequences. And it's important to note that almost all of the components of these are subjective. If you have an advanced pelvic MR radiologist review scans, they'll tell you that usually these aren't cut and dry. For example, saying whether there's residual lymph nodes or not, saying whether there's residual T2 signal, whether there's residual diffusion-weighted imaging, it's quite subjective. And importantly, these new criteria, although I think they're a step in the right direction, they have not been validated in prospective series. What about post-treatment surveillance after non-operative management? Memorial and Maastricht are advocating for a fairly intensive surveillance strategy, especially in the first 2 years, as their data and others suggest that most of the recurrences happen in the first 2 years. But we do know that recurrences can happen later down the road as well. And these schedules are quite intensive. They require a compliant patient who needs to come back to the clinic every 3 months for both advanced imaging and endoscopy. And although one could argue that organ preservation may be cost-effective because you're avoiding an expensive surgery up front, I think that this intensive follow-up schedule, definitely in the first 2 years to 5 years and beyond, likely erode some of the cost effectiveness of avoiding a surgery up front, and in the long run may end up being actually more costly. It's also important to note that most of the published series have come from centers that have extensive experience, specialized multi-modality, multidisciplinary GI oncology teams, which include gastroenterologists who have experience in doing endoscopy and identifying changes after chemoradiation and assessing whether there's residual scar versus ulcer versus tumor. Colorectal surgery groups that have experience in operating in patients who have undergone pelvic radiation and may have increased scarring, increased difficulty in the operation. Centers that have advanced imaging capabilities and have dedicated radiologists that have experience in interpreting rectal MRIs, which, as we mentioned, can be very difficult in the post-treatment setting. Pathologists who can identify biopsies after neoadjuvant therapy and make that critical call as to whether they're seeing residual viable cancer versus post-treatment effect. Radiation oncology, medical oncology teams, again, because we're talking about intensifying treatments, neoadjuvant therapy treatments. And I would argue that this may not be practical at many of the U.S. community oncology practices, which is where most of the rectal cancer patients are cared for today. And I'd like to highlight a potential hazard in dissemination of non-operative management. This is a recent provocative study presented in JCO where they looked at the National Cancer Database and looked specifically at use of non-operative management for patients with stage 2-3 rectal cancer. They noted there's been an increased utilization, although overall relatively small number of patients in the US are being managed with this strategy. Interestingly, they noted that utilization of non-operative management was associated with Black race, uninsured Medicaid patients, and at low-volume care centers. And while this may be a reflection of barriers to care in the United States, it certainly raises the question as to whether this new innovative approach is being adopted in centers that may not have the resources available to implement it. And here's an example that we recently saw at our tertiary care center. So a 43-year-old man with a distal rectal cancer, biopsy-proven adenocarcinoma, had staging, was a T3N1. He was cared for in the community. Plan was for chemoradiation, then an APR. He had treatment, had a complete response by DRE, endoscopy, PET, CEA. The patient had been on the internet and heard that surgery may not be needed for my rectal cancer if I have a complete response. And so he refused an APR. Non-compliant with follow-up, comes back 2 years later with rectal bleeding and basically has a massive recurrence in the rectum, invading the prostate, requiring a total pelvic exoneration. What do the current published guidelines say about non-operative management? Currently, the NCCN panel does not recommend this approach for routine management of localized rectal cancer. European guidelines, this approach has not been evaluated in prospective trials. So while I agree that non-operative management certainly is a promising strategy that deserves further evaluation, I think that it should be done in the context of prospective trials or registries that are carried out by specialized multidisciplinary teams. And at present, it shouldn't be offered as a routine option for patients outside of these guidelines.